Hi, I'm Greg Sayuk from Washington University in St. Louis, and I'd like to share with you some pearls that I've gained over the years through my experience in the use of neuromodulators for the management of abdominal symptoms in patients with irritable bowel syndrome. I think the first thing you want to do in incorporating the use of neuromodulators in your practice is to choose neuromodulators from different classes of agents that you become familiar with in terms of the dosing of these agents, in terms of the potential side effects of these agents, and really incorporate these into your practice. So selecting perhaps one or two agents from the tricyclics, for example, selecting one or two agents from the SNRIs that you may want to use, and so forth, and become really familiar and comfortable with the use of these agents. As a corollary to that point, I think it's important to recognize that there probably is some specific benefit to the use of agents that have a norepinephrine effect. So I tend to focus a lot on the tricyclic agents such as nortriptyline, which I commonly use, or amitriptyline, as well as the SNRIs, where we're talking about agents such as duloxetine or venlafaxine. This is where I would focus a lot of your initial experience if you're not as familiar with using neuromodulators for the management of IBS in your patients. Now, another important point, I think, is to have a discussion with your patient about the use of these agents. It's important to refer to these agents as neuromodulators rather than antidepressants, because we understand that these medications do a lot more than just affect the mood. These agents probably have beneficial effects on neurotransmission, on the brain's response in terms of the emotional and the cognitive responses to the pain signals that come from the bowel. And so referring to these agents as neuromodulators, I think, helps the patient to understand that we're not treating their mood with these medications. We're rather trying to treat the hypersensitivity, the abdominal symptoms that commonly associate with these disorders such as irritable bowel syndrome. Another pearl that I think is important to address in using these agents is to take some time to discuss the potential side effects of these agents with your patient. I try to spend a few minutes highlighting the main things they need to be aware of. The fact that in the case of the tricyclics, for example, oftentimes they'll early on experience anticholinergic side effects, dry mouth, perhaps some sedation. They may experience some slight worsening of constipation, even some autonomic symptoms like dizziness as they initiate the course of the treatment. It's important that you do this because if you don't, when the patient does have some of these side effects, they may become alarmed and they may discontinue the use of this medication. And the end result will be that they're going to be reluctant to trial future neuromodulators down the road if they don't have a positive experience with that initial exposure or use of a neuromodulator. Lastly, I think it's very important to recognize that we try to start low and go very slow with the titration of these agents. So I typically will start, in the case of a tricyclic antidepressant, 10 to 25 milligrams at bedtime, and I will let the patient acclimate to that medication over a few weeks to even a month or two. Realize that there's data that some patients will even respond and continue at a very low dose of tricyclic antidepressant in that same range. So there's no need to be aggressive about escalating doses from 10 to 25 to 50 milligrams and upwards. Very slow, gradual increases in dose will maximize the potential that that patient will tolerate the medication well. My last pearl would be to have a mechanism in place for regular follow-up of these patients. So I typically will try to reach out to the patient or have my nurse or medical assistant reach out to the patient a week or two after initiating the medication. Again, with the idea that if they are having any challenges in initiating that treatment, that they don't discontinue it, that we help to work them through it so that they have a positive experience with that agent down the road. Hopefully these tips have been useful to you. If you're less familiar with using neuromodulators, I think you'll find them to be one of the, if not the most effective class of agents available for the management of the abdominal symptoms that your patients with IBS experience. Thank you.